SmithKline and French Laboratories is very pleased to bring you these highlights from a symposium on panic disorder, which we sponsored at the 1986 annual meeting of the American Psychiatric Association Convention in Washington, D.C. Dr. John Nemiah opens the symposium with a brief overview of the historical perspective of panic disorder. But first, here's a short message from SmithKline and French Laboratories and SK&F Co.
Your patients, their journey from fear, slow passage from a dark world of chaos to the ordered vision of reality. Your patient's progress is a tribute to your talent, your painstaking skill, and the benefit of modern psychotherapy.
Today, more than ever before, we feel it's important to remind you that when you wish to ensure the continuity of treatment so valuable to your special patients, it's up to you, the prescribing physician, to demand that the drug you prescribe is the drug they receive. To protect your patients, protect the integrity of your prescription. Always write Stelazine DAW, do not substitute, or use the format required by your state.
For almost 30 years, psychiatrists have relied on Stelazine in the familiar True Blue tablets to maintain their chronic schizophrenic patients through effective control of psychotic target symptoms.
And since, as you know, Stelazine apparently activates withdrawn, apathetic, or detached patients, you have a greater opportunity to reach your patient with other forms of therapy. Your patient suffers less, responds faster.
In addition, Stelazine offers these treatment benefits. Stelazine seldom causes excessive sedation. Stelazine demonstrates a low risk of anticholinergic effects and hypotension. Stelazine offers convenient, economical BID dosage.
And while Stelazine shares the increased risk of extrapyramidal symptoms associated with all high-potency neuroleptics, these symptoms, when encountered, are generally readily controlled.
We urge you to prescribe prompt, non-addictive, activating Stelazine for your chronic schizophrenic patients.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions such as pseudoparkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with Stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing Stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions.
Be sure you're the doctor. Always write Stelazine DAW, dispense as written, or do not substitute. Or use the formula required by your state. Protect your patients. Exercise your right.
And now, Dr. Nemiah at the symposium. Dr. Nemiah is professor of psychiatry at the Dartmouth Medical School, psychiatrist-in-chief emeritus at Beth-Israel Hospital, and professor of psychiatry emeritus at Harvard Medical School.
Familiarity with the physiognomy of madness, if you will, goes back many centuries, if not millennia. Attempts to impose an orderly classification upon it are perhaps more modern. As physicians toward the end of the 18th and on into the 19th century began to focus their clinical attention more specifically on patients with mental disorders, they were really concerned with diagnosing, classifying, and treating illnesses that were psychotic rather than neurotic in nature. And I think we might well say that the medical specialty of psychiatry was really born in the madhouse. Now, this is not to say that neurotic disorders were entirely overlooked or ignored. Hysteria, of course, had from time immemorial been known and diagnosed by physicians throughout the Western world, and along with neurasthenia and hypochondriasis, then constituted really the entire universe of non-psychotic nervous illness. At a time when finally Janet and Freud entered on the scene at the end of the 19th century. Between the two of them, I think one might say that, like Pericles in Athens, they found neurosis a village of brick and left it a city of marble, which is only now being subjected to the inevitable American urban renewal of DSM-3 and 3R and 4. Now, Janet, as we know, working at the Salpêtrière, was initially concerned with the study of patients with major hysteria, but he soon turned his attention to individuals with a wide variety of neurotic symptoms, which he described graphically in his many clinical volumes. Janet was thoroughly familiar with panic attacks and agoraphobia, and let me just read you a brief case from Janet, written in 1889, which shows the depth of his knowledge and phenomenologically. He writes of a young man, or not so young, he was 52, named B.U., and he writes as follows: when he was about 25, there started what he himself called the business with spaces. He was crossing the Place de la Concorde, alone it should be noted, when he felt a strange sensation of dread. His breathing became rapid, and he felt as if he were suffocating. His heart was beating violently, and his legs were limp, as if half paralyzed. He had to exert a tremendous effort, bathed in sweat, to reach the other side of the square. From the time of that first episode on, he took a great dislike to the Place de la Concorde and decided he would not risk going there again. His illness continued to develop slowly. The anxiety he would then experience whenever he had to venture out into a place was so severe that it became impossible for him to control it, and he was no longer able to cross any square. Some dozen years ago, he had to escort a young girl to her house. As long as he was with her, everything was all right, but when she had left him, he was unable to go back home. 5 hours later, he had not yet returned. His wife became alarmed and went out in search of him. She found him ashen and shivering with cold on the edge of the Place des Invalides, which he had completely been unable to cross. And then, following that experience, he could not go alone without his wife. His wife had to hold him tightly by his arm, and then he would calm down and cross any square without further incident. His wife has to accompany him everywhere he goes now, even when he goes to the toilet. Janet had two major classifications of neuroses. There was hysteria, and then there was psychasthenia, which included phobias, obsessive-compulsive symptoms, neurasthenic symptoms, as well as the symptoms of anxiety and panic, which he described here. Like Janet, Freud made major contributions to the nosology and the theory of the neuroses that, unlike those of his French contemporary, became finally the dominant psychiatric conception of neurotic disorders, especially in America. He carved out the phobic disorder, obsessive-compulsive disorder, anxiety neurosis, as he called it, along with hysteria, leaving out only the more depressive symptoms. And these, up until the DSM-3 at least, were the classical neurotic disorders in American psychiatry. Freud's early formulations have a very strangely modern ring. He called clinical anxiety and anxiety neurosis not a psychoneurosis, since it had, he said, no psychical origin. He said, one finds the recollection of an anxiety attack, and what the patient actually fears is the occurrence of such an attack under the special conditions in which he believes he cannot escape it. The findings from recent observations, from ego psychology, from behavioral psychology, from biological investigation, have, I think, provided a scientific basis once again for the dual concept of anxiety, that there are really two kinds rather than the single theory of anxiety which has predominated up until recently. But as we can see from Freud's formulations, as a clinical concept, the dual notion of anxiety goes back many decades. As we turn to a survey of the many new and exciting biological, behavioral, and psychodynamic facts and theories about anxiety and phobic disorders, I think we should keep in mind that they really are, as I've tried briefly to indicate here, extensions of the clinical work and findings of those who have preceded us. Let me call on Dr. Thomas W. Uhde, who will talk to us on the phenomenology, biology, and treatment of panic.
In considering the phenomenology and course of illness, one has to have a working definition of panic attacks and obviously agoraphobia. One also has to keep in mind the differential diagnosis of panic attacks. I think you're all familiar with the DSM-3 criteria of panic attacks. Panic attacks are discrete episodes of profound anxiety, very profound anxiety, that require 4 of the following symptoms: dyspnea, palpitations, chest pain. Chest pain can be quite severe. It can be very similar to the chest pain associated with an impending myocardial infarction. Pain can radiate up into the neck and even down into the arm. There is sometimes a choking and smothering sensation. There can be dizziness, lightheadedness, unsteady feelings. There can be, in addition to feelings of unreality, a wide range of different psychosensory disturbances that occur during panic attacks. Paresthesias, tingling sensations in the hands and feet, and also around the mouth, are not uncommon symptoms during panic attacks. There can also be hot and cold flashes. Sweating frequently occurs. Sweating is usually localized to the hands, the feet, the forehead. Total body sweating, where the whole body is drenched, is fairly unusual, and in fact, when that takes place, one should entertain the notion of a pheochromocytoma. Trembling, shaking, and a fear of dying, or the fear that the patient is going to do something unexpected or out of control, is what makes up the constellation of symptoms of panic attacks. Now, agoraphobia. I think all of us are familiar with the term. Agoraphobia is a marked fear of and avoidance of being alone or in any place where help would not be available in case of sudden incapacitation. In patients with panic disorder, in our experience, the fear is that they will experience a panic attack out of the blue, unprovoked, in a situation where they cannot receive immediate help. This anticipatory anxiety about having a panic attack leads to increasing constriction of normal activities, and ultimately fears or avoidance behaviors dominate the individual's life. Now, in order to meet diagnostic criteria of panic disorder, with or without agoraphobia, one needs to rule out underlying medical problems, as I mentioned before, medical problems which could account for the panic attacks. And I'd like to mention 3 medical conditions which inevitably come up in a discussion with patients about their panic attacks. The first one is hypoglycemia. Inevitably, in working with a patient with panic attacks, he or she will ask, is this caused by hypoglycemia or abnormally low blood sugars? The bottom line that I'd like you to go away with is that hypoglycemia is rarely the pathogenesis of anxiety episodes in patients presenting with agoraphobia. In any number of patients where we have evaluated their glucose levels during spontaneous panic attacks, the glucose levels are normal. So that is the bottom line. However, panic disorder patients can experience hypoglycemia in addition to their panic attacks. And the panic disorder patients can easily distinguish the symptoms of hypoglycemia from the spontaneous panic attacks associated with their disorder. If you look at these symptom characterizations, you can see some difference. Panic attacks occur randomly, although there is some recent data to suggest that there may be a more frequent prevalence late in the evening, the later afternoon. That needs to be confirmed with more systematic studies. Reactive hypoglycemia occurs regularly 3 to 5 hours after eating a meal. There's also some symptoms such as hunger and a coarse tremor that are associated with the hypoglycemia that are very unusual in panic attacks. Patients with panic attacks do not normally complain of severe hunger during their panic attacks. That's a very common symptom during hypoglycemia. Another point to mention is that even in patients that have documented hypoglycemia, the development of agoraphobia following hypoglycemic episodes is quite rare, whereas agoraphobia following the development of panic attacks, spontaneous panic attacks, is a quite common occurrence. Now, the other and second medical condition that inevitably comes up for consideration is the differential diagnosis of panic disorder from complex partial seizures. And Sir Martin Roth, years ago, noted the similarity of the symptoms in complex partial seizures compared to panic disorder. There are, however, a number of symptoms that can guide the clinician in the differential diagnosis. Patients with complex partial seizures commonly experience gustatory, tactile, and stereotype repetitive movements or motor automatisms during their episodes, which are very, very rare in panic attacks. So any patient that complains or has these signs or symptoms need to be evaluated very seriously for an underlying seizure diathesis. Now, the third condition is the anxiety states associated with caffeine intoxication or caffeine withdrawal. The problems associated with both of these conditions can come very close to the symptoms that you see in panic disorder patients. Nervousness, irritability, tachycardia. In the caffeine intoxication state, it is virtually indistinguishable from a symptomatic perspective from the spontaneous panic attacks associated with panic disorder. Even withdrawal from caffeine can be associated with a marked anxiety syndrome, as was noted by Dr. Graydon a number of years ago. In fact, we have seen individuals where both caffeine intoxication and caffeine withdrawal appear to be occurring within the same 24-hour period of time. So making the distinction between panic attacks, caffeine intoxication, and withdrawal is important for the clinician, particularly in a patient that comes to the emergency room, is complaining of the first series of panic attacks, and has been driving long distances and consuming large amounts of coffee in order to remain awake. Caffeine intoxication can clearly mimic panic disorder. So there are three conditions: hypoglycemia, complex partial seizures, and caffeine intoxication or withdrawal that need to be entertained in the differential diagnosis. Now, when a person has excluded a medical condition to explain the panic attacks, one needs to know about the natural course of illness of panic disorder, with or without agoraphobia. And a number of years ago, an individual we are all familiar with, Sigmund, noted that in the case of agoraphobia, we often find the recollection of an anxiety attack. And what the patient fears is the occurrence of such an attack under the special conditions in which he believes he cannot escape. So a number of investigators have noted the relationship between panic attacks followed by anticipatory anxiety and then agoraphobia. We have found that 98% of the patients that have both panic attacks and agoraphobia, that panic attacks precede the onset of agoraphobia. What else do we know about the phenomenology of panic disorder, with or without agoraphobia? To mention the DSM-3 criteria for panic attacks, we also find that there are a number of psychosensory disturbances associated with panic attacks. Some of these disturbances, in fact, may be more frequent than some of the DSM-3 criteria. So patients frequently complain of distortions in light intensity or sound intensity. Derealization is not uncommon, and a strange rising feeling in the stomach occurs in approximately 41% of the patients. So these types of symptoms need to be kept in mind in evaluating patients as well. If you look at the types of fears that are reported by agoraphobic patients, there are a wide range of fears that they report. And in fact, in a patient that comes to your office and complains of what appears to be a simple phobia, such as a fear of elevators or escalators, one needs to evaluate the possibility of multiple fears, in which case the patient is likely to have a diagnosis of agoraphobia. Now, what about the type of depression that occurs in panic disorder? In our experience, the depression and panic disorder, when it occurs, is quite similar in character in most respects to the types of depressions reported in patients with primary affective disturbances. Most of these symptoms overlap across the two disorders. There are two dimensions which, however, seem to distinguish the two disorders: psychomotor retardation and suicidal ideation, in our experience, is quite rare in panic disorder patients, even during their depressive episodes, but are not uncommon, obviously, in patients with major depression. From this perspective, the fact that there is a clinical overlap in the symptoms of depression, the fact that patients with panic disorder frequently respond to many of the same medications that are helpful in the treatment of major depression, and recent epidemiological data suggesting a linkage between panic disorder and major depression provides a framework, an anchoring point for discussing the biology of panic disorder. And what I would like to do is go through a number of biological indices which have been relatively consistently reported to be disturbed in depression and compare those disturbances in major depression to what we find in panic disorder. The first thing that we want to address from this type of approach is the nature of panic disorder from a biological perspective. There are three possibilities. All three possibilities have been hypothesized by experts in the area. The first hypothesis is that panic disorder and major depression are totally distinct and separate disorders with no overlap in the underlying neurobiology. The second hypothesis is that they have the same underlying biological pathogenesis with different clinical presentations. And the third possibility, which I consider the most parsimonious hypothesis, is that these are separate disorders with some overlapping aspects in both their clinical presentation as well as underlying biological substrates. Now, everyone is familiar with the dexamethasone suppression test. There are hundreds of people that have studied the dexamethasone suppression test in major depression. Approximately 50% of patients with major melancholic depressions will escape with a dexamethasone suppression test. The vast majority of studies of panic disorder indicate a normal dexamethasone suppression test. Avery and colleagues did find a similar rate of escape in depressed outpatients to panic disorder patients, and Bueno and colleagues reported that depressed panic disorder patients also had an increased rate of escape. But overall, there appears to be a normal dexamethasone suppression test in panic disorder. Everyone is familiar with the sleep architecture and REM latency in major depression. There is a decrease in REM latency in major depression. The sleep architecture of panic disorder appears to be quite different in our experience. And while we have found a very mild decrease in REM latency, it is not nearly as robust a decrease as one finds in major depression. So sleep architecture seems to distinguish the two disorders. And a very interesting dimension that we have recently looked at is the effects of sleep deprivation in patients with panic disorder. You may be familiar with the behavioral response to sleep deprivation in melancholia. It is sometimes used, in fact, as a treatment in European clinics. But it is clear that in a very severely retarded melancholic patient, that approximately 60% of those patients will have a transient improvement in mood following 24 hours sleep deprivation. The problem is that when they return to sleep, there is usually a relapse in symptomatology. Nonetheless, it is an interesting marker or index of behavior in relationship to sleep in major depression. In panic disorder patients, again in a study that we completed recently in our laboratory, we found that panic disorder patients, rather than improving, basically had a fairly marked exacerbation of their symptomatology. Some panic disorder patients did not significantly worsen, but a number of them did have a profound increase in symptoms of anxiety, including 4 patients that experienced panic attacks during the sleep deprivation paradigm. So the sleep deprivation response also appears, like the sleep architecture, to distinguish between panic disorder and major depression. In summary, there does appear to be some differences, clear differences in the neurobiology of these two disorders, and there appears to be an overlap. The dimensions which distinguish the two disorders are the abnormal dexamethasone suppression test, the marked reduction in REM latency, and the positive mood improvement following sleep deprivation, which seem to be characteristic of melancholic depressions. One thing that needs to be kept in mind is that the panic attacks is the force behind alterations in a number of these other dimensions, but they're intricately intertwined. So patients with panic disorder can have alterations in their cognitive style and in their cognition. There is clearly a great deal of anxious expectation, which can be exacerbated and driven by panic attacks. And this anxious expectation as well can, in my opinion, increase the frequency of panic attacks. Panic attacks can increase avoidance behaviors, and avoidance behaviors themselves can have an impact on anxious expectation. as well as probably on the frequency of panic attacks. But the point that I would like to get across is that these are intimately related. They're intertwined. So when one uses pharmacological treatment, it would not be unexpected to find alterations in these other dimensions. If one attacked the syndrome from a cognitive therapy perspective or a behavioral perspective, it would not be unexpected to see changes in these other dimensions. So they're related. However, I would take the position that panic attacks are the driving and principal force behind the development and disturbance in most of these symptoms. In clinical practice, there are a number of predictors that we look at. This information is derived from our clinical experience and is not data that's based on systematic studies. We try to look at predictors of positive response to drug therapy. Classic panic attacks. And what do we mean by classic panic attacks? If a patient comes and says that the panic attacks come out of the blue, they're unprovoked, they were unexpected, I would consider that a classic panic attack, particularly if those types of panic attacks occurred early in the course of illness. Patients with these types of classic panic attacks can easily recall the precise time, place, and situation of their first panic attack. They don't ramble, they don't hem and haw, they can tell you exactly what took place, even if it occurred 10, 15, 20, or 25 years ago. In our experience, a typical course of illness, which also seems to be related to positive response to drug treatment, is panic attacks which precede the anticipatory anxiety, followed by agoraphobia. And lastly, patients that have a good premorbid or pre-attack personality appear also to be good responders to pharmacological interventions. Some predictors of poor response reflect the opposite polarity. A patient with atypical panic attacks comes in and says, I have these profound episodes of anxiety, and during the anxiety attacks, I have the desire to kill myself, slash my wrist. That's atypical. That's not the standard history that a patient with classic panic disorder will give. If a patient can always anticipate their panic attacks, there's never a period of time where they've had unexpected panic attacks. That's relatively unusual, and in my opinion, a relative predictor of poor response. In patients where the predominant symptoms of the panic attacks are psychosensory in nature, so that they don't report disturbances in the autonomic nervous system. They come in and they principally complain of psychosensory disturbances, feeling out of their body. They as well do not appear to respond as well to medications as those without the more predominant autonomic symptomatology. There are patients that actually seem to be able to think themselves into panic attacks. In our experience, they are less responsive to medications than those that seem to feel that the panic attacks come out of the blue. I believe that one needs to evaluate personality structure very carefully. There are a number of personality traits which seem to work against pharmacological interventions. Patients with borderline personality traits, particularly those that are relatively impulsive, that are involved in self-damaging acts, even if they have panic attacks, they do not appear to respond to medications as well. And also there are compulsive personality traits. Indecisiveness, due to fear of making a mistake, is a problem in the clinician that wants to use medications. Obviously, if a patient is preoccupied that a quarter of a milligram of alprazolam will lead him or her to overdose on the medication, it's going to be a problem getting them up to the appropriate medication level. In conclusion, the phenomenology seems to be fairly clear that panic attacks precede anticipatory anxiety, followed by agoraphobia. 50% of these patients have a lifetime prevalence of depression. There are a number of neuroendocrine and noradrenergic alterations. These patients appear to be particularly vulnerable to caffeine, lactate, and yohimbine. And we require greater study in order to determine the clinical and biological predictors of this disorder, both in the treatment from a pharmacological perspective as well as cognitive, behavioral, and insight-oriented psychotherapy. Thank you very much.
This concludes the presentation by Dr. Thomas Uhde, who is Chief of the Unit on Anxiety and Affective Disorders at the National Institute of Mental Health in Bethesda, Maryland. Please turn the cassette over for the continuation of this symposium on panic disorder, etiology, and treatment. Highlights from the SK&F sponsored Symposium on Panic Disorder continue with the discussion of behavioral aspects by Dr. Isaac Marks. We will precede Dr. Marks' comments with this message from SmithKline & French Laboratories.
Gradual release action is the only major advance in lithium therapy since the discovery of lithium for the treatment of manic episodes in manic depressive illness. Consider the benefits of Escalith CR, brand of lithium carbonate, the controlled released 450 milligram tablets from SmithKline & French Laboratories. Escalith CR therapy diminishes the serum level peaks and valleys associated with conventional immediate release lithium medications. The 450 milligram tablet strength of Escalith CR may make it simpler when you want to switch patients from a TID to a BID dosage regimen. Finally, BID dosage with Escalith CR encourages long-term therapeutic compliance, an important advantage given the grave implications and mounting statistics on noncompliance. If you are not familiar with the benefits of gradual release action, we hope this message encourages you to consider the use of Escalith CR 450 milligram controlled release tablets for your manic depressive patients with a history of mania.
Lithium should generally not be given to patients with significant renal or cardiovascular disease, severe debilitation, dehydration, or sodium depletion, or to patients receiving diuretics. Lithium may cause fetal harm when administered to a pregnant woman and is not recommended in children under 12. Lithium toxicity is closely related to serum lithium levels and can occur at doses close to therapeutic levels. Facilities for prompt and accurate serum lithium determination should be available before treatment is begun. Patients should be cautioned about activities requiring alertness. Before prescribing Escalith CR, please consult the accompanying complete prescribing information including warnings, precautions, and adverse reactions.
If you have any questions about Escalith CR, we invite your inquiries. Please write to the Medical Department, SmithKline & French Laboratories, Post Office Box 7929, Philadelphia, Pennsylvania, 19101. That's Post Office Box 7929, Philadelphia, Pennsylvania, 19101.
Now, let's get back to the symposium for Dr. Marks' presentation. Dr. Marks is Professor of Experimental Psychopathology at the Institute of Psychiatry and Maudsley Hospital in London, England. The self-exposure treatment summarized in his lecture is detailed in the paperback book Living with Fear, published by McGraw-Hill in 1980.
There are two types of panic in panic disorder. The first is phobic situational panic, which occurs in the great majority of cases, in other words, in those who have both panic disorder and agoraphobia. This is phobic or situational panic, which is predictably triggered by a characteristic cluster of agoraphobic situations. The situations that evoke phobic panic in agoraphobics may be either real or imagined. It can be brought on either by actually going to those situations or by merely thinking about them, or by looking at films about these situations. And anticipatory phobic panic is cued by thinking of the relevant situations. A critical concomitant of phobic panic in all phobias, including agoraphobia, is avoidance of those cues that regularly trigger panic. This leads to handicap if the avoided situations are frequent in everyday life, which is the case in agoraphobia. This situational phobic panic is the hallmark of all phobics, not only agoraphobics. The subjective, behavioral, and physiological features of phobic panic are similar across the various types of phobia, and indeed in normal panic, for example, in soldiers under bombardment. All have tachycardia, all have tachypnea, sweating, and an urge to run away. Now, the second type of panic that one gets in panic disorder, but much less so in other forms of phobic disorder, is the spontaneous or non-situational panic. What is the cause? Insofar as everything has a cause, there must be some hidden trigger for spontaneous panic, but that trigger is not a particular external situation or thought about such a situation. Speculations about possible precipitants of spontaneous anxiety range from discharges in the locus coeruleus to unconscious fantasies. There's a continuum between spontaneous anxiety and spontaneous panic, which corresponds to that in situational or phobic anxiety. both with respect to the duration and intensity of the phenomenon. Tonic tension and surges of spontaneous panic merge into one another and are highly correlated. Spontaneous panic may occur without agoraphobia, which gives you the DSM-3 category of panic disorder without agoraphobia. But as we've already heard, it's also common in major depression. And most agoraphobics have both spontaneous and situational panic. There is good reason to separate agoraphobia from panic disorder without agoraphobia, despite the many intermediate cases. Unlike pure panic disorder cases, agoraphobics not only panic in certain situations, but also tend to avoid them. And it's this avoidance par excellence that is the cause of their difficulty, the change in their lifestyles, and their social handicap. Why avoidance is much more likely to develop to outside situations than to home situations in which panic has been experienced is a mystery. It might be that as a species, we are more prepared to link panic to places outside our home territory than inside it, though this is probably not the whole story. We don't know why the spontaneous panic of panic disorder often gets conditioned to the situations in which it occurs, becoming transformed into the situational phobic panic and avoidance so typical of agoraphobia. The various modes of onset of agoraphobia resemble those found in other phobic disorders and in obsessive-compulsive disorder. Although it is often thought that agoraphobics always start with a series of spontaneous panics, in fact, in many cases, early episodes may merely consist of twinges of mild anxiety that over successive episodes gradually mount in intensity until one day it becomes a complete panic. Turning to treatment, the great strength of the behavioral approach to panic disorder is its quick and effective guidance to treating most cases. In behavioral treatment of panic disorder, the clinician starts by mapping out the patient's agoraphobic avoidance profile. What is the patient avoiding? For how long has he been avoiding this? And this is the first step in developing an exposure treatment strategy that can be effective without needing much time from the clinician. Controlled trials in the United States and in Europe have repeatedly found that agoraphobia does well after exposure treatment, and that gains persist up to 4 to 7 years follow-up, which is far longer than any follow-ups that have been done after drug treatment has been stopped. Effective applications often require the clinician to devote no more time to the patient than is customary with drug treatment and other widely used forms of psychiatric treatment. This encouraging development, whereby clinicians can give the behavioral treatment very economically, partly arises from the recent move away from the idea of behavioral treatment as something done to patients towards a realization that behavioral methods form a system of self-help that the patient learns from a clinician who is largely acting as coach and monitor. You have, of course, to assess the nature of the problem in the clinic, suggest the behavioral methods, largely live exposure, to produce improvement, and then the patient takes over here. The patient practices these methods in the natural situation, records the outcome in a daily diary. This is extremely helpful in keeping the patient's nose to the grindstone, in keeping him targeted on exactly what's necessary, and you can quickly pick up what he's done and how he's progressed as results. You monitor the results. And then you repeat all these until adequate improvement is obtained and, of course, follow-up. Even severe agoraphobia can respond with very little therapist investment. Merely appropriate advice. There are some patients who need only a little bit of self-help instruction, and that's all they need. After that, they go off and they do all their own treatment. Others need a little bit more help from the clinician. Some may need the clinician to actually accompany them into the phobic situation the first, perhaps even 2 or 3 times, but not more. Those who need the therapist to accompany them all the time are a lost cause, because at some point the clinician has to fade out of the scene and the patient has to do it herself or himself. Fortunately, the great majority of cases allow the clinician to fade out. And the amount of time we have had to spend treating patients has dropped greatly in the last few years since we've adopted the self-exposure model. Can behavioral treatment offer anything to the minority of cases of panic disorder who have no agoraphobia? In theory, yes, you could perhaps habituate the patient to imagined cues of anxiety, internal cues, but the research remains to be done. At the moment, we just don't know. There's no doubt at all that drugs have a part to play in dysphoric agoraphobics. Whether it helps agoraphobics without dysphoria is still a question that's much debated, but by no means a cut and dried story about the antidepressants, quite apart from the danger of relapse when one stops drugs. To sum up, the behavioral approach to panic disorder distinguishes between agoraphobic and spontaneous panic and emphasizes the disability caused by avoidance of a particular cluster of public places. Panic disorder might be a less viable label than is agoraphobia. Behavioral treatment delineates the agoraphobic avoidance and panic profiles and encourages a self-exposure program to produce habituation. It is usually of durable efficacy and needs little time from the psychiatrist. Antidepressive drugs can be added when dysphoria is present and do not interfere with exposure. Thank you.
Next on the program is a discussion of the psychodynamic aspects of panic disorder by Dr. Graeme Taylor, Associate Professor of Psychiatry at the University of Toronto, Canada, and head of the Behavioral Medicine Clinic at Mount Sinai Hospital in Toronto.
Let us now examine Bowlby's attachment theory and the recent proposal that links panic disorder to separation anxiety. You will recall that Bowlby rejected Freud's view that the infant's attachment to the mother is secondary to her role in providing satisfaction of the infant's oral instinctual needs. Bowlby argued that attachment behavior and the separation response of intense protest followed by despair and detachment are in fact instinctive behaviors that can be observed in a wide range of animal species. He proposed that infants are born with a biological and evolutionally based predisposition to seek proximity to the mother who provides protection from predators, thereby making survival more likely. Bowlby's attachment theory casts new light on the problem of separation anxiety by considering it a direct response to the loss or threat of loss of the mother rather than the consequence of accumulated drive and need tensions. In other words, the great source of terror in infancy and childhood, if not throughout life, is solitude, as William James claimed around the time that Freud was presenting his first theory of anxiety. Bowlby linked anxiety disorders in adult life to the experience of long or repeated separations or frequent threats of such during childhood. And more recently, Donald Klein has suggested that panic disorder may be a pathological variant of normal separation anxiety. This idea stemmed initially from Klein's observation that important clinical features of agoraphobia, namely clinging, dependent behavior, and intolerance of being alone, resemble the manifestations of separation anxiety. In addition, Klein found that patients with panic disorder frequently give a childhood history of marked separation anxiety and difficulty adjusting to school, and that their initial panic attack is often preceded by a significant object loss. Subsequent research has shown that panic disorder in parents confers more than a threefold increased risk of separation anxiety in children, and that imipramine helps both children with separation disorder and adults with panic disorder. Adopting Bowlby's attachment theory, Klein hypothesized that there is an innate biological control mechanism that causes the separated infant to emit distress signals, the protest response, that will retrieve the mothering figure. And Klein suggests that like other biological control mechanisms, there is a wide range of variations in strength and threshold, and that patients prone to panic attacks have a constitutionally determined lowered threshold for separation anxiety. Now, this is an interesting hypothesis, but like Freud's first theory of anxiety, it is essentially somatopsychic in nature, focusing solely on central nervous system mechanisms. And since psychodynamic and behavioral events are regarded as secondary phenomena, it offers the psychotherapist little more than a supportive role in the treatment process. Klein is certainly justified in challenging the traditional psychodynamic view of panic attacks and agoraphobia, but his hypothesis is limited by its failure to incorporate the modern psychoanalytic conception that human relationships and the world of internal object representations also have important homeostatic regulating functions. In other words, while genetically determined neurotransmitter systems undoubtedly play an important role in regulating the activity of the biological control mechanism for separation anxiety, a person's close relationships, symbols, and inner psychological life might also modulate its activity. For instance, we know that disruptions in significant interpersonal relationships can activate the anxiety control mechanism and that reunions quieten it down, and we also know that agoraphobic patients are often helped by having an almost constant companion who appears to function as an external regulator of the patient's apparently unstable biological control mechanism for anxiety. This knowledge allows us then to modify Klein's hypothesis and to reconceptualize panic disorder as a disorder of self-regulation arising at the boundary between psyche and soma. Now let me elaborate on this unified psychobiologic model by looking more closely at the processes of separation and attachment within the early mother-infant relationship. In replacing Freud's tension reduction model of the mother-infant relationship by an object relational model, Bowlby focused mainly on the observable behaviors between mother and infant. And in so doing, he overlooked other important processes that are hidden within the normal interactions between mother and infant. And these hidden processes play an important role in the regulation of anxiety and in maintaining homeostatic equilibrium in the infant. The traditional psychoanalytic view of attachment was initially challenged in the 1950s by Harlow's now classic studies of infant monkeys raised by surrogate mothers. And you will recall this dual surrogate situation where the infant monkeys spent most of their time clinging to the soft terry cloth mothers, even though the nursing bottle was attached to the hard wire surrogate nearby. And even during feeding, the infants maintained some bodily contact with the soft terry cloth mother. Harlow's experiments demonstrated that bodily contact plays an important role in the attachment process and that infants need much more than the mere satisfaction of their oral needs. But despite Harlow's monkeys becoming attached to these terry cloth mothers, they turned out to be strikingly abnormal in their behavior. While growing up, they developed stereotyped body rocking, and as adults, they had difficulty mating, they were fearful of social encounters, and they mistreated their offspring. And quite clearly, much more was yet to be learned about both the psychology and the physiology of the early mother-infant relationship. It's during the past decade that human and animal infant research has greatly increased our knowledge of the mother-infant relationship, and some of this knowledge can help us begin to understand more about the etiology of panic disorder. By studying the relational field between mother and infant, researchers have demonstrated that the mother-infant relationship functions as an interactional system that organizes and regulates much of the infant's behavior from birth. Study after study has shown that the infant is engaged in object-relating behavior right from the very start of life. Furthermore, what the infant does will influence how the mother responds. Careful observations have shown that both mother and infant use repertoires of behavior to initiate, reinforce, and regulate the other's behavior, much like the participants in a dance. Even the rhythm of the infant's limb movements are synchronized with the rhythm of the mother's speech. In addition to numerous observable regulatory behaviors within the mother-infant relationship, it appears that there are probably also several hidden sensory motor processes whereby the mother can regulate aspects of the infant's biology until self-regulating mechanisms mature. We still know very little about the physiology of the human mother-infant relationship, but animal research has identified various hidden nutritional, tactile, thermal, and vestibular processes whereby the mother serves as an external regulator of the infant's behavior, its autonomic physiology, and even the neurochemistry of its maturing brain. Several other animal studies have provided evidence that the infant's homeostatic organization is an open system rather than a closed system as previously thought, and that some of the infant animal's responses to separation are therefore biological release phenomena. It is obviously a large leap from the animal laboratory to the human nursery, but developmental biologists suspect that similar hidden sensory motor processes are also present within the human mother-infant relationship. And if this is true, then the infant's responses to separation are due not simply to the breaking of an attachment bond, but also to withdrawal of the external biological and behavioral regulation supplied by the mother. And animal research has also shown that the withdrawal of these hidden regulatory processes in early life can affect the animal's homeostatic organization and thereby alter susceptibility to disease later in life. Likewise, disruptions in the early human mother-infant relationship might modify the genetic expression of the biological control mechanism for separation anxiety and produce the lowered threshold that's been postulated by Donald Klein. This may be activated later in life by the stress of a real or threatened object loss. Let us now consider how the infant normally progresses from a state of initial dependency on the mother as an external regulator of anxiety and other psychobiological states to a state of independency and autonomous functioning. This is accomplished by the maturation of internal homeostatic mechanisms and by the process of internalization that results in mental representations of the infant's tie to the mother. This internalization process is hidden within the normal interactions between mother and infant, and like the hidden sensory motor processes, was also overlooked by Bowlby when he focused only on the observable behaviors of the infant and the mother. The establishment of intrapsychic representations and the gradual replacement of interactional regulatory processes by self-regulating mechanisms is frequently facilitated by the child developing an attachment to a soft inanimate object such as a blanket or a stuffed toy animal that becomes a substitute for the mother. You're all familiar, of course, with Linus and his security blanket. These attachment objects are called transitional objects because they arise during that intermediate or transitional period when the child is beginning to separate from the mother and individuate, but before self-regulating capacities have fully evolved. Like the terry cloth mothers preferred by Harlow's monkeys, the transitional object provides tactile sensations that are reminiscent of the early bodily contact with the mother. In addition to the tactile sensations, the infant brings the transitional object to his face, smells it, places parts of it inside his mouth, suggesting that it may regulate separation anxiety by means of olfactory pathways as well. And these tactile and olfactory sensory motor mechanisms are comparable to the hidden sensory motor processes that have been discovered within animal infant-mother relationships. The child's transitional object is initially pre-symbolic and is used mainly to recapitulate certain sensations or bodily rhythms. But in the course of normal development, it is gradually endowed with psychological meaning and comes to represent the mother in a symbolic way, and thereafter the transitional object reduces the child's separation anxiety by evoking the illusion of a reunion with the absent mother. Transitional phenomena such as babblings, tunes, nursery rhymes, and imaginary companions can also represent the mother and provide anxiety relieving and other functions that previously required her presence. What then is the fate of the transitional object in the course of normal development? Just as the child develops intrapsychic representations of the parents with their regulatory functions, so it internalizes the soothing and anxiety-regulating functions of the transitional object, which become part of the child's self-regulating psychic structure. The cuddly blanket, or soft stuffed toy animal are eventually discarded, but they are replaced by dreams, fantasies, play, religion, and other creative interests that evoke a similar illusory state in which an individual can transcend his sense of separateness. Patients with panic disorder often show deficits in symbolic functioning and an impaired capacity for transitional relatedness. And these deficits can be traced to early developmental disturbances when the mother has traumatically interfered with the individuation of the child. While a physically absent mother obviously subjects the child to the trauma of prolonged separation anxiety, the child may also be traumatized by a mother who is present but emotionally unavailable and less involved in developing reciprocal regulatory interactions with her child. Mothers who are depressed or who suffer from anxiety disorders themselves may behave in rejecting or overly protective ways that interfere with the development of a transitional object. And some of these mothers actually maintain a pathologically dependent relationship with their child to relieve their own fear of being alone. They may discourage separation, individuation, by failing to reward the child as he begins to experiment with physical separation from the mother, and they may also withdraw their support when the child needs to fall back on the mother. In this way, they create a dilemma in which the child resents being tied to the mother, but experiences guilt over normal strivings to separate and individuate. The failure to establish stable mental representations of the self and of the attachment figure results in self and ego deficits and an impaired capacity for regulating anxiety and other psychobiological states. These deficits may be compensated for by excessive and prolonged dependency on an external regulatory relationship, but the individual remains predisposed to panic disorder or some other disorder of regulation because the self fragments when faced with separation from or loss of the regulatory relationship. In conclusion, I will quickly summarize the principles of dynamic psychotherapy for patients with panic disorder. First of all, psychotherapy must be integrated with pharmacotherapy and or behavior therapy. It is the rare patient who benefits from dynamic psychotherapy alone. Second, that the psychotherapy should be based not on the traditional drive, conflict, defense model of the mind, but on current knowledge about the development of the ego and of the self within the context of human relationships. The therapist therefore needs to explore the quality of the patient's past and present object relationships, and after identifying self and ego deficits, the therapist can begin to develop or restore interactional and self-regulating processes that will help stabilize the biological control mechanisms for anxiety. This is a complex and difficult task, often requiring the analysis of primitive internal object relations before a regulatory transference relationship can be established. Within that transference relationship, the therapist fosters symbolization that will permit the emergence of transitional phenomena and the development of stable mental representations with anxiety-regulating functions. While anti-panic medication usually provides rapid symptom relief, psychodynamic psychotherapy has the potential for improving self-regulatory mechanisms and thereby reducing the patient's susceptibility to recurrences of the disorder. Thank you.
Dr. Taylor's presentation concludes our program of highlights from the Symposium on Panic Disorder, Etiology and Treatment, recorded on location at the 1986 annual meeting of the American Psychiatric Association. SmithKline & French Laboratories sincerely appreciates the cooperation of the American Psychiatric Association in the production of this continuing education service. The views expressed here are those of the individual physicians, whose participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline & French Laboratories or any other manufacturer of pharmaceuticals mentioned. This program was produced by SmithKline & French Laboratories and SK&F Co.